Welcome and thank you for joining Cancer Support Community Atlanta for this program. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website, cscatlanta.org, and complete a new attendee form to stay connected to all future programs.
Dr. Franco is a medical oncologist with Georgia Cancer Specialists, is board certified in medical oncology, hematology, and internal medicine. So again, we are very grateful for him doing this presentation today. He has treated many patients with this disease. So we are excited to have him speaking. And Dr. Franco, do you want to say anything before you get started?
No, I'm ready. I'm ready to go.
All right, wonderful. Well, without further ado, let's go ahead and get started.
Okay, so I just want to make sure I'm doing this right. I'm going to be talking about myeloproliferative neoplasms. They used to be called myeloproliferative disorders, and because of the fact that they are neoplasms, because there is uncontrolled proliferation of cells, which is abnormal, I guess the decision was made to change the name to myeloproliferative neoplasms. There are 5, but I'm going to be talking about 3, and I will explain that later. I have to say that this is one of my babies. I'm a hematologist by training. I love the practice of hematologic malignancies, and this is one of them. Myeloproliferative neoplasms. This is what I do day in, day out. An example of other hematologic malignancies are chronic leukemias like myeloid and lymphocyte leukemia, myelodysplasia, multiple myeloma, lymphomas. So those are all examples of other hematologic malignancies. Now, I'm a hematologist by training. I'm board certified in hematology, and I've been practicing at the Northside Hospital Cancer Institute in Atlanta for 32 years, and used to be the director of the transplant program from 1997 through 2001. I'm very proud of that because the bone marrow transplant program at Northside Cancer Institute is one of the best in the country. I don't do the transplants anymore, but I will mention transplants at the end of the presentation. The myeloproliferative neoplasms that I'm going to be talking about today are myelofibrosis, Polycythemia Vera, and essential thrombocythemia. There are a couple of others that are in the classification now, or one of them has been in the classification for a long time. Chronic myeloid leukemia, we don't include that in this talk because that's a talk on its own. Chronic myeloid leukemia is essentially, quote, curable, unquote, because patients survive forever as long as they take a TKI, a medication to inhibit the genetic changes that cause chronic myeloid leukemia. So we don't include that here. The other disease that we don't include in this presentation is chronic myelomonocytic leukemia. It is this condition, CMML, as opposed to CML that I mentioned before. CMML, chronic myelomonocytic leukemia, is in the classification of the myeloproliferative neoplasms now, but also is in the classification of myelodysplasia. And it was considered a myelodysplasia until recently. And it's a disease with different mechanisms of disease and also different treatments. So we don't talk about this condition here today. So I'm talking about the 3 conditions that are included in the classification of myeloproliferative neoplasms, or that are considered myeloproliferative neoplasms in talks like this. So myelofibrosis is basically scar tissue in your bone marrow. The median age of diagnosis, as you can see here, is 60 to 67. The bone marrow, the classic bone marrow abnormality is excess fibrous tissue. This is scar tissue. Okay, we call it fibrosis, but it's, you know, for lay people, is scar tissue. Having scar tissue is like the scar tissue that you develop like a keloid, or scar tissue that you develop after a cut or after surgery, after a surgical opening. There is also increase in megakaryocytes, which look abnormal. These megakaryocytes, which are the mother cells that produce platelets, these cells are increased in fibrosis, in fibrotic marrows, and also they look abnormal. Now, what are the blood cell abnormalities in myelofibrosis? Generally an anemia. An anemia is the most likely finding in the blood, and many times there are increased white cells and also increased platelets. But the most common finding is anemia, decreased red cell count. The survival in fibrosis, depending on the stage, is 2.25 years to 11.25 years. Now, I've had patients with very early myelofibrosis that I have followed for 20 years, but this is medium. 2.2 years for advanced fibrosis, 11.25 years for early fibrosis. And there is a genetic change that is called JAK2 mutation that is present in about 50% of patients, okay, in fibrosis. In Polycythemia Vera, the median age is 60. There is proliferation of all cell lineages. So if you do a bone marrow on a P. Vera patient, you will see increased red cells, increased white cells, and increased platelets in the bone marrow. Now, the abnormalities that we see in the blood count, they are all increased in most patients. Increased red cell count is a hallmark. Most patients present with a very high hemoglobin, very high hematocrit. And some patients also present with increased white cells and or increased platelets. The median survival, 14 to 19 years, 1.2 years in advanced disease who has failed treatment with hydroxyurea. But as I said before, I've seen many patients surviving more than 15 or 20 years with any of the myeloproliferative disorders, including P. Vera. The diagnostic test is the JAK2 mutation. Over 95% of patients have a JAK2 mutation, exon 14 in the JAK2 gene, but there are a few, 3 to 5%, that have a mutation in the exon 12 up to exon 15 of this genetic, of the gene of JAK2. It's very unusual to see a P. Vera patient with a negative JAK2 mutation, extremely rare. The other one is ET, or essential thrombocythemia. Okay, and this is the US prevalent. As you can see, I forgot to mention the myelofibrosis is only seen in less than 20,000 patients that are alive in this country. Less than 20,000 patients, that's the prevalence in this country. Close to 20,000 patients with fibrosis. About 100,000 patients living with P. Vera in this country, and about 70 to 90,000 patients living with ET in this country. Median age for essential thrombocythemia, 60, increased megakaryocytes in the bone marrow, increased platelets, that's the usual presentation, with normal white blood cells and normal red cell count, generally only increased platelets, anywhere from 500,000 to 2 million, approximate survival, 20 years. Now, many patients have a normal lifespan. In fact, there was a study from France that was published more than 20 years ago that showed that generally 90% plus of these patients have a normal lifespan. But we say that the median survival is approximately 20 years because there are a few that will transform into acute leukemia or will evolve to fibrosis, okay? And the JAK2 mutation is present in 55% of patients. Now, there is another mutation that is common that is newer, that is common in ET, which is called CALR, C-A-L-R, that is present in up to 70% of patients with essential thrombocythemia, and also could be present in myelofibrosis. And a few, 3 to 5%, will have another mutation that is called MPL, M as in Mary, P as in Paul, L as in Larry, MPL, in a few patients. But the most common in ET is CALR, C-A-L-R, in about 70%. Now, P. Vera is characterized by increased production of blood-forming cells, all of them, because they are all increased, but the most important abnormality is a very high red blood cell count or hemoglobin count. Again, the characteristic mutation is the JAK2 mutation. It's a genetic abnormality in this gene that is called the JAK pathway. There is an overactive JAK pathway signaling in more than 95% of cases. This JAK pathway is important for hematopoiesis, or production of blood cells, and also for production of immunoglobulins, the JAK1. The JAK2 pathway in erythropoiesis, JAK1, is for reaction to inflammation. It has a lot to do, and in fact, JAK1 may be very activated in COVID infections that present with very high CRPs, very high inflammation in the body, what we call the cytokine storm that has been found to be present in COVID infections. But the JAK2 is a pathway that has to do with the production of blood cells. Now, patients may be producing blood cells not only in the bone marrow, but also in other sites like the spleen. So that's what we call extramedullary hematopoiesis. So there are other places like liver and spleen that may begin producing blood cells in this condition. There are abnormal levels of inflammatory cytokines, and like the CRP, C-reactive protein, and long-term complications like blood clots. I've seen patients over the years that presented to me with a blood clot in the legs, like what we call blood clot DVT, or blood clot PE, pulmonary embolism, that later were diagnosed with P. Vera. This is not an uncommon complication of P. Vera, venous thrombosis. Occasionally, we also see arterial thrombosis like heart attacks or strokes. So there is another complication, or what we call gout. Patients may present with gout, or may also present with what we call erythromelalgia. Erythromelalgia is a significant rash, very angry looking, generally in the lower extremities, that goes away or improves with aspirin treatment. Signs and symptoms of P. Vera: fatigue, concentration problems. Remember, the blood is thick. It flows slowly because of the thickness of the blood from so much red cells. Early satiety, itching, especially itching after a shower, inactivity, weight loss, fever, bone pain, night sweats, abdominal discomfort from a big spleen. 50% of patients have a big spleen. They could also have peripheral edema. Many patients present with no symptoms whatsoever. In fact, most of the patients that I've seen over the years had no symptoms, and the primary care doctor sent them to me because they had an elevated red cell count. Many times that elevated red cell count is due to testosterone treatment or because patients smoke. So that's the most common in the differential diagnosis. I've seen many patients over the years who did not have an elevated red cell count from P. Vera, but from smoking so much, and also from testosterone treatments. Now, patients with P. Vera may have had a previous blood clot arterial, including stroke or MI, myocardial infarction, or venous, either superficial or deep thrombosis or pulmonary embolism. Other manifestations are, as I mentioned before, erythromelalgia from excessive dilatation of the blood vessels in hands and feet, and rash, angry rash, scotoma, like blind spot in their vision, tinnitus, which is the ringing of your ears, migraines or seizures, and unlikely. Vertigo could be a symptom also. But again, many times there are no symptoms or signs. Criteria for polycythemia vera requires 3 major criteria, or first, the first two, I'm sorry, I need to go back. Okay, the first 2 in the major criteria and a minor criteria. And these are the major criteria: hemoglobin over 16.5 or hematocrit over 49% in men, 16 and 48 in women. Then you rule out sleep apnea, which also causes elevation of red cell count, smoking, as I mentioned before, chronic asthma with low oxygen, testosterone use, or people that live in high altitudes. People that live in the Alps or in the Andes Mountains in South America, they usually have a high red cell count because they need higher red cells to carry oxygen. So those are all in the differential diagnosis. Bone marrow biopsy shows hypercellularity because the bone marrow produces too many red cells, white cells, and platelets, and the presence of the JAK2 mutation, either exon 14, which is the V617F, or the JAK2 exon 12 mutation. Those are the 3 major criteria. The minor criteria: subnormal serum EPO level, erythropoietin level. In fact, before we have the JAK2 mutation available for diagnosis, we used to diagnose with P. vera with a low EPO level and a deficiency of iron or low ferritin in the blood, because patients with P. vera are generally deficient of iron because they run out of iron from producing too many red cells over the years. Okay, so although high red blood cell counts is the most prominent feature of polycythemia vera, patients may also have elevated white cell counts or increased platelet counts. Treatment of polycythemia vera, it depends on really the high risk or the risk stratification. If the patients have a history of blood clots over age 60, hematocrit over 45, and white cells over 11,000, those are high-risk patients and they need to be treated. And I will mention the treatments now. Phlebotomy is bloodletting, or removing blood from you, generally a pint of blood every time. Now, this is the most common treatment initially for P. vera, removing blood so that the men are kept with a hematocrit under 45 and women under 42, which is a criteria put together by an expert at Johns Hopkins, less than 45 in men, less than 42 in women. Now, phlebotomy is less likely to be used in patients over 70 because phlebotomies have been found to increase risk of blood clots in patients over 70. Now, patients who do not like patients who do not like the phlebotomies and prefer not to have them, or that need too many of them, or patients over 70 are treated with hydroxyurea. Hydroxyurea is a drug, is a chemotherapy drug that is very effective in this setting and extremely safe. It generally has no side effects and you can use it for years. Occasionally it causes sores in the legs or ulcers in the legs, but that's extremely rare. So you can be on Hydrea 500 milligrams to 2 grams every day for a long time without any problems. Now, interferon has also been used, but has more side effects like fatigue, depression, low blood counts, but it is extremely effective also. There are several studies from Mayo Clinic and MD Anderson that show the benefit of interferon. It used to take 3 injections a week with a lot of problems with depression and fatigue, but now you can take only 1 shot a week that is extremely well tolerated. But we don't use it that much because of the availability of the next medication that is called Jakafi generic ruxolitinib for patients that are intolerant or have inadequate responses to hydroxyurea. Ruxolitinib is extremely effective, improves quality of life, improves survival, decreases the size of the spleen. So in patients that cannot take hydroxyurea or do not tolerate hydroxyurea, we go to Jakafi, generally about 15 to 20 milligrams daily with excellent tolerance. Occasionally, patients develop anemia or bruising or headaches, and very rarely can develop a tumor in the skin that is called Merkel's cell tumor. Now, ET, we're moving to the next one. ET, essential thrombocythemia. Again, some patients live a normal life or have a normal lifespan, but the average life, median life in patients with ET is 20 years. Many patients survive with more than 1 million platelets without any problems, especially younger patients. I didn't mention this before, but I'm going to mention it now. Anybody with P. Vera or essential thrombocythemia has about a 5 to 10% risk of transformation into fibrosis or myelofibrosis in the bone marrow. And generally 5% to 10% risk of acute leukemia, which is the reason why we follow these patients, because again, a few may develop acute leukemias. I have followed many patients over the years with either essential thrombocythemia or polycythemia vera, 15, 20 years, who never developed a complication of fibrosis or acute leukemia, but have also had a few patients over the years that developed myelofibrosis in the bone marrow and a progressive anemia, and also a few patients that developed acute leukemia and died, or developed acute leukemia and had successful chemotherapy treatment. So yes, this is one of the main reasons we follow them, because a few will develop acute leukemia 10, 15, 20 years later. Now, essential thrombocythemia is often identified on routine blood work with an elevated platelet count. Now, what is the differential diagnosis here? There are many women that I see in my practice, essentially younger women, that present with high platelets because they either have a profound deficiency of iron or a chronic immune or inflammatory disease like lupus, rheumatoid arthritis, or chronic liver diseases or chronic inflammatory diseases. Platelets could be elevated as a reactive phenomenon in patients with chronic immune or inflammatory diseases, but we hardly ever see a count over 1 million. Patients with profound deficiency of iron could also have an elevated platelet count, but again, we hardly ever see over 1 million, usually 700 or 800,000. You treat the deficiency of iron, or you treat the inflammatory disease, and the platelets go down. But that's in the differential diagnosis. Now, patients with essential thrombocythemia do not have deficiency of iron and do not have any immune or inflammatory disease that could cause the platelets to go up. Patients with ET have symptoms generally associated with blood clots, headache, dizziness, visual changes, numbness and tingling in hands and feet, difficulty speaking, or weakness in one side of the body. But most patients present with no symptoms and no signs. I have had patients that have had more than 1 million platelets without blood clots. And I have also had patients with high platelets who presented with bleeding, because about 50% of the patients that have high platelets have dysfunctional platelets, or platelets that do not work well, and that leads to bruising or bleeding. So you cannot just use aspirin on everybody until you know for sure that these patients do not have dysfunctional platelets or that have symptoms or signs of blood clots. Criteria for ET. ET requires all 4 major criteria that we'll be discussing soon, or the first major criteria and 3 of the minor, or the first 3 major criteria and some minor criteria. So the major criteria, platelet counts over 450,000. And a bone marrow biopsy that shows increased number of megakaryocytes, the cells that produce platelets, or enlarged or abnormal megakaryocytes, without any significant abnormality in the white cells or red cells in the bone marrow, with very rare increase in reticulin, which are the fibrosis fibers. ET patients do not meet any criteria for chronic myeloid leukemia, P. Vera, fibrosis, or myelodysplasia. So they only have criteria for essential thrombocythemia, and they may have a JAK2 mutation exon 14 that is positive in about 50–55%, or a CALR mutation, calreticulin mutation, CALR, in about 70 or 80% or so of the patients, or MPL mutations, which are present only about 5%. Minor diagnostic criteria, the presence of a clonal marker, which is one of these markers are clonal markers, JAK2, CALR, or MPL, or absence of evidence of reactive thrombocytosis. What I mentioned before, patients do not have a chronic inflammatory disease that is associated with elevation of platelets, or a profound deficiency of iron, which may be associated with elevation of platelets. The risk stratification, how is that we say to a patient, you have low risk or high risk? Very low risk is less than 60 years of age, no JAK2 mutation or negative JAK2 mutation, and no history of thrombosis. That patient has a very low risk and does not need to be treated. Low risk, less than 60, positive JAK2 mutation, no history of thrombosis. That patient generally doesn't have to be treated either. We can just watch the platelet count. Intermediate risk, more than 60, over 60 years of age, no JAK2 mutation, no history of thrombosis. These patients may need treatment or may not. You just have to evaluate the patient and decide and check the platelet count, and and then you decide whether the patient needs treatment or not. High risk, over 60, history of thrombosis, positive JAK2 mutation, that definitely need to be treated. Those patients need to be treated. You use hydroxyurea plus aspirin as long as the patient doesn't have bleeding or bad bruising. If the patient presents with dysfunctional platelets, and you can check that, there is a test that is called platelet function screen. If the platelet function screen is abnormal, you cannot use aspirin because the patient is gonna bruise badly or bleed. But more than 50% of patients are candidates for aspirin with the hydroxyurea to decrease the platelet count. Now, if the patients do not respond to hydroxyurea or do not tolerate hydroxyurea, you could use agrelin, or what we call an agrelide. But the problem with an agrelide is headache. A lot of people have headaches. So you need to sort of watch for side effects, okay? And the other treatment is interferon. If the patient is treatment, yes, also the same experience in ET has been had by experts that have also treated P. Vera. Very effective, and also now we have moved from 3 shots a week to 1 shot a week. But again, more side effects like fatigue and depression. Many of these patients have to be an antidepressant when you put them on interferon. But it could be very effective if the patient cannot respond or does not respond to hydroxyurea, or if the patient has too many headaches on an agrelide, okay? Myelofibrosis, the last one that we're gonna be talking about, a disease that has, has had much better prognosis with the availability of Jakafi or ruxolitinib over the last several years. Many years ago, we didn't have any treatment, but Jakafi could be very effective in this setting. The key finding is fibrosis or scar tissue of the bone marrow, what we call reticulin fibrosis. The disease progression is variable. There are periods of very stable disease and some periods of rapid progression. Okay, the most common finding at presentation is anemia, and the other one is splenomegaly. Patients who present with a moderate to significant anemia or a big spleen that does not allow them to eat a good meal, they get full too early during a meal, and they have pain in the left side of the abdomen because they have a big spleen, okay? Now, primary myelofibrosis was described in 1879, so, a long time ago. There is leukemic transformation in a significant number of patients, up to 20 to 30%. I have to say that in my practice, I haven't seen that much, perhaps 10, 15%, perhaps because I've seen a lot of patients with low grade or low risk myelofibrosis that sometimes survive beyond 15 or 20 years. They have high levels of circulating inflammatory cytokines like IL-6, which is what we see in COVID now. But the most common cytokine that is tested in blood on a routine basis is what we call CRP, C-reactive protein, easily available. You can do a CRP anytime in any day at the practice. And generally those are over 15 or 20, high CRP, high set rate, over 80 to 100, the sedimentation rate. And significant anemia is predictive of poor survival. I've had a couple of patients who presented with a hemoglobin of 12 in their 40s. They were both men, so a hemoglobin of 12 for women is normal. A hemoglobin of 12 for men is low. It's an anemia because men have to have more than 14.5. Women have 12, 12.5 as normal because of the menstrual periods. But men with a hemoglobin of 12 have an anemia. These two patients, I evaluated them in the 90s, in the 90s, 20 years ago, more than 20 years ago. They were both in their 40s, early 40s, so younger patients. And they are still alive without evidence of progression more than 20 years. They only had a hemoglobin of 12. They never had a progressive anemia, and their spleens were normal. So they are still alive without any progression. But if the anemia is significant, let's say less than 10 hemoglobin, the survival is poor. A progressive anemia or significant anemia is not good. Okay, now, secondary myelofibrosis is the one that patients develop after being diagnosed with polycythemia vera or essential thrombocythemia. The transformation rate per 10 years in polycythemia vera is over 10%. In ET is much less, only over 4%. So there are less patients with essential thrombocythemia that evolve or progress into myelofibrosis than patients with P vera, which is more than 10%. Okay, so patients with P vera or essential thrombocythemia could develop fibrosis or myelofibrosis in the bone marrow over the years. Okay? Now, signs and symptoms of myelofibrosis. Okay? Fatigue, itching, night sweats or fevers, enlarged spleen in 95% of patients, enlarged liver, weight loss, bone pain, not joint pain, bone pain, difficulty concentrating, numbness, tingling in hands and feet, ascites or accumulation of fluid inside the abdomen, or fluid in the pleural space outside the lungs. Now, not all patients present with all of this. A few patients just present with fatigue and itching or night sweats. Other patients present with a big spleen and left abdominal pain. Other patients present with weight loss or, neuropathy or difficulty in concentrating. So not everybody presents with all these symptoms. Most patients present just with 3 or 4 of these. So it's very rare to have all the symptoms. Now, the first patient that I treated with Jakafi many years ago, perhaps 7 years, 8 years ago, the first patient I treated with the Jakafi, which is ruxolitinib, came to me from hospice. He had already been referred to for hospice care at home, but the daughter, who was a nurse in our practice, decided to bring the patient to me for another opinion. When I saw him, the patient had lost at least 30 to 40 pounds, had ascites, a lot of fluid in the abdomen, and a huge spleen. He also had significant fatigue and also night sweats. And when I saw him, his hemoglobin was 7.58, actually 8.5. So I said, listen, I could give you ruxolitinib. The problem is your anemia could get worse. The first several weeks of ruxolitinib, you could have bruising and headache. And, you know, he was excited, you know, when he heard that there was a drug that I could use. I went ahead and started him on Jakafi. The first few weeks, obviously, his hemoglobin went to 7.5. He had to get some blood transfusions, but later, after 2-3 months on Jakafi, and we had to decrease the dose of Jakafi because of the anemia, but later we were able to increase the Jakafi dose up to 15 milligrams twice a day. That was the maximal dose that we could use, but I didn't really care because that now we know that 15 twice a day is the minimal effective dose. It could be as effective as 20 or 25 twice a day. So the patient survived 2 years with a much improved quality of life, and then finally died with progressive bone marrow failure. But the patient was supposed to go home and die 2 years before I was able to start Jakafi. And again, had excellent response to Jakafi over 2 years, and had a 2 years of good quality at home with his family. So let's see. Diagnostic criteria for primary myelofibrosis requires all 3 major criteria and at least 1 minor. Major criteria: the presence of a JAK2 mutation, a CALR mutation, or an MPL mutation. Abnormal megakaryocytes and presence of reticulin or collagen fibrosis in the bone marrow. And the pathology is great, the fibrosis in the bone marrow, 1+, 2+, 3+. And that's very helpful too in terms of prognosis. 1+ survives way longer than 3+. So that's something that we can discuss with the patients. And then the other major criteria is not meeting criteria for chronic myeloid leukemia, P. Vera, ET, or myelodysplasia. Minor criteria: anemia not related to anything else, like kidney disease. Many patients with kidney disease present with anemia. Minor criteria: white blood cells over 1,000, enlarged spleen, elevated LDH, and occasionally what we call leukoerythroblastosis. Occasionally in these patients who present with anemia, this is a prognostic system for myelofibrosis. And each of these on the left represent 1 point, with the exception of significant anemia in the dips, that is 2 points. So I'll tell you, if you're over 65, in the dips is the dynamic international prognostic scoring system, is 1 point. Now, this DIPS plus is called plus because it adds 3 other findings that I will explain later. So age over 65 is 1 point in the DIPS and 1 point in the DIPS plus. Constitutional symptoms like night sweats, weight loss, fever, 1 point in the DIPS, 1 point in DIPS plus. Hemoglobin less than 10, which is a significant anemia. DIPS 2 points, DIPS plus 1. White blood cells more than 25,000, 1 and 1. Circulating blasts. Blasts are very immature cells. the most immature white cells in the bone marrow that are released into the blood. And basically, that's what we call leukoerythroblastic picture or leukoerythroblastosis. These are acute leukemia cells. The presence in fibrosis doesn't mean that the patient has acute leukemia, because we generally see some of these cells in the blood. If we see these, 1 point each. Platelets less than 1,000 is only in the DIP plus, 1 point. Transfusion dependent of red cell transfusions, 1 point in the plus. Karyotype is the cytogenetic findings. Most hematologic malignancies, most of the leukemias, lymphomas, cancers of the blood have abnormal chromosomes in the blood or in the bone marrow. So many of these patients with myeloproliferative neoplasms may have abnormal chromosomes. And there are some chromosomes that are associated with better prognosis, like in myelodysplasia, deletion 5, for example. Deletion 7 is bad. Now, in this case, myelofibrosis, unfavorable karyotype or chromosomes that are associated with poor prognosis are inversion of chromosome 3, and 17q, which is an abnormality of chromosome 17. That has 1 point. So, prognosis, low risk disease, no risk factors, median survival 15 years. I've had a lady from Venezuela who is not able to come back to see me anymore because of the trouble in that country. But I used to see her yearly. I follow her more than 20 years with low risk disease, with no evidence of progression, just a little anemia. Intermediate 1, and how do you get to those categories? You add the numbers, okay? You add these numbers, okay? These numbers in the DIPs or these numbers in the DIP plus. You add the numbers. Low risk, median survival 15, intermediate, median survival 7 years with 1 risk factor, intermediate, 2 or 3 risk factors, median survival 2.9, high risk, 4 or more risk factors, median survival 1.3 years. See, the patient that came to me that I described to you before had a median survival of less than 1.3 years from diagnosis. He had been diagnosed a year before and was sent to hospice. When he came, he should have been dead or dying. But ruxolitinib gave him a couple more years. So the prognosis or the survival depends on how low the risk is or how high the risk is. And again, all of this are the risk factors. But one thing that is not here that we also consider when we talk with patients is the degree of fibrosis or scar tissue in the bone marrow. 1+, 2+, 3+. Treatment of MF, conventional treatments to alleviate symptoms, aspirin or Tylenol for fever, for bone pain, hydroxyurea to decrease counts. If a patient has a high white blood cell count, that's not good. Patients who have a lower white cell count also do better than patients that have over 25,000 white cells. So it's a good idea to decrease the white cell count as long as you don't worsen the anemia, because hydroxyurea may decrease white cell count on platelets, but it could also worsen the anemia. So you couldn't use hydroxyurea if the hemoglobin is 9 or less. You can use it if it is 11 or 10, like Jakafi. Sometimes patients need steroids. There is a drug that has been used in hematologic malignancies like myeloma, thalidomide, which could help, lenalidomide, but we used those before ruxolitinib or Jakafi became available. Now, we used to use splenic radiation to the spleen in patients with huge spleens and painful spleens. The problem is that the radiation to the spleen is only short-lived, or the benefit is short-lived. It doesn't last that long. So we don't use it anymore now that we have ruxolitinib, which decreases the size of the spleen. Hydroxyurea may improve counts, but it does not decrease the size of the spleen. Now, the only curative treatment is bone marrow transplant, okay? But we use bone marrow transplants only for patients that are felt to have, patients that are younger than 70, that are felt to have a survival of less than 5 years. So intermediate 1 or 2 patients that have this kind of survival, because the mortality could be very high. 100-day transplant-related mortality is 18–20% for patients with match-related donor, so a family donor. It could be up to over 30% for match-unrelated donor, so a donor from the registry or an unrelated donor. Now, if you use what we call reduced intensity conditioning, what does that mean in a transplant setting? That is when you use less chemotherapy, lower doses of chemotherapy to kill the patient's bone marrow. So the mortality goes down to 10%, but the relapse of the disease or the control of the myelofibrosis goes down. So the transplant becomes less effective if you use reduced intensity conditioning. Now, graft failure in transplant is 9%. What does that mean? That the transplant doesn't take in about 10% of patients or so. For match-related donors, family members, to 20% for match unrelated. So this is when we use transplants from an unrelated donor, the graft may not take in about 20%. So as you can see, there are several problems related to transplanting these people. That's why we never transplanted my patients that I mentioned, those guys that were diagnosed with fibrosis in the early 40s with anemia. I sent them to Fred Applebaum, who is a transplant expert at the Fred Hutchinson Cancer Center in the 90s. Now I would not send him there because the Northside Transplant Center is one of the best in the country with the lowest mortality for allogeneic transplant. So now I can just send the patients across the street for a consultation. But in the 90s, the best transplant center was Fred Hutchinson in Seattle. So these 2 patients were seen by Fred Applebaum there, and he said, no transplant unless there is progressive anemia or any transformation or worsening fibrosis. So lucky, because these patients were never transplanted and they are still alive without any problems. The relapse rate is lower in patients transplanted earlier in the course of disease. But again, if a patient has a good quality of life, a hemoglobin over 11 or 12, 1 or 2 plus fibrosis in the bone marrow, less than 60 years of age, then I would never transplant that patient. 5-year survival rate for transplant is only 30 to 60%. So again, we don't cure everybody. Now, markers of match-related donors. That means that if a patient had a transplant, there is a possibility that the JAK2 mutation present in that patient may go away or may disappear. And if that's the case, if the JAK mutation disappears with the donor transplant from a family member, there is a lower relapse, so the patient survive longer and the transplant may be more successful. So I think that's it. So I have time for questions now. I'm not gonna talk anymore about transplants. I have a few more slides, but no, I've been talking for an hour, so that's enough. So any questions?
Yes, thank you, Dr. Franco. We do have multiple questions I'll read out to you. We have one participant joining us from Canada who wants to know about recommendations for someone to see in the United States. She was diagnosed with MPN unclassified and is triple negative for the big 3 mutations, and wanting to see someone in the US, thinking maybe that there's more patients like her here.
Well, I mean, there is a Stan Vertovsek. Vertovsek is an expert in at MD Anderson. There is also Ruben Mesa, M-E-Z-A, at the Mayo Clinic. And the number 3 is me. I don't think you can see anybody better than me. I mean, I'm sorry to say that. You know, I like to be a humble person, but, you know, I don't want to throw flowers on me or anything like that. But I don't think you can see anybody better. I mean, that's why I'm doing this talk. But I'm not in academic medicine. I am in clinical practice. I'm the founder, one of the senior partners, the founder of this group. And I love hematologic malignancies. I go to every ASH meeting every year. So I'm updated. I read blood, the best hematology journal. So I don't think you can find a doctor in academia that is more updated, but there are experts, yes. Ruben, I would recommend Dr. Mesa, Ruben Mesa at the Mayo Clinic, Dr. Vertovsek at MD Anderson, and there is another doctor, I'm sorry, his name escapes me right now. I can't remember his name. He's another expert. There is one more that is excellent. I think he's in New York. But again, I can't remember now. I'll try to think and remember. He's
Wonderful.
also excellent.
Good, thank you. And just a reminder, Dr. Franco is presenting today from Georgia Cancer Specialist with Northside Hospital in Atlanta, Georgia. Another question, does secondary smoking affect the platelet count in ET?
You know, I can't say that for platelets. I can tell you that smoking increases the risk of myelodysplasia, which is damage to the stem cells in the bone marrow, because each cigarette causes mutations in the blood cells and also lung cells. And also, there was a study from Spain published about 10 or 15 years ago that showed that heavy smokers have an increased number of white cells on a regular basis in the blood. So leukocytosis, but no, there wasn't any mention about platelets. So I couldn't tell you that this is published or confirmed, no. But those are the things. It increases the risk of myelodysplasia, and it could increase your white cell count. Oh, I just remembered the name of Dr. Teferi. Teferi, T-E-F-I, I'm sorry, T-E-F-E-R-I. That's another doctor. Can't remember his first name. Dr. Teferi is also an excellent doctor for consults on myelodysplasia. Oh, I'm sorry, myeloproliferative neoplasms.
Okay.
Any other question?
I'm 32 and was diagnosed with ET 5 months ago. Is it more likely for someone younger to mutate to multiple fibrosis? Also, I'm triple negative.
Now, what is your platelet count?
Myelofibrosis, I'm sorry.
Oh, you were diagnosed with myelofibrosis?
And also triple negative.
Or ET?
Diagnosed with ET, wants to know if someone younger could mutate to.
Now, I need to know if she had a bone marrow biopsy and what is her platelet count?
Okay, Cassie said 32 years old from Chicago, triple negative ET with platelet of 980, have symptoms, dizziness, lightheaded. I'm 1500 mg daily, HU.
Yeah, but what about bone marrow? Did she have a bone marrow biopsy or not? You don't know?
She said yes. I don't know if it was to answer that question.
Okay. Okay, I just wanted to know if there was any fibrosis in the bone marrow.
No fibrosis.
Good. You know, I am a little bit concerned about her symptoms when she presented, but most of the patients that I've seen in that age group have had a normal or near normal lifespan. And again, I'm going to refer you to this study. I can't remember when it was published. I think it was New England, but it was more than 20 years ago. A study from France that showed that the overwhelming majority of patients with ET over 90% have a normal lifespan. So, you know, obviously, if you have symptoms, that concerns me because that means that there was some problem with the circulation. And also the fact that you're taking 1.5 grams of hydrea daily. Now, I don't know how much the platelets have dropped with the hydrea. One thing that is important to know is that, in my opinion, it is not necessary to normalize the platelet count. So it isn't that you have to take hydrea to a platelet count of 200,000. No, I mean, it's, you know, you could decrease the platelet count, and if you don't have any symptoms with 600,000 or 700,000, that's fine with me.
Her pancreas was removed 2 years ago. She has 20% pancreas left.
What about the spleen? Did they remove the spleen?
She had a 7.8 centimeter cyst inside. Nothing about the spleen.
The pancreas would have nothing to do with that. The pancreas, nothing. But many times, people that have pancreas surgery end up with the spleen removed. And if the spleen is removed, the spleen could cause an increase in platelets. In fact, most patients that have had the spleen removed have an increased number of platelets, not ET.
If my first bone marrow biopsy shows early MF, when would you recommend doing another one?
Only if you develop a progressive anemia or a progressive elevation of white cells. Or perhaps if you develop symptoms, all of a sudden you start losing weight, having fever, night sweats, bone pain, weight loss, you know, I would do that. Otherwise, no. Progressive anemia, elevated white cells, a progressive elevation of white cells, or significant symptoms.
Okay, if you are overall very healthy, does this affect the lifespan of someone with an MPN?
You know, no. I mean, the survival would be related to the degree or severity of the MPN. It doesn't really matter whether you are healthy or not. I mean, obviously, a healthy person is not likely to have complications from other diseases, but the survival depends on the degree or severity of the MPN or transformation into leukemia or progression to fibrosis. Now, if you have diabetes, then your survival may be shorter because you may develop a heart attack sooner rather than later. You know, so the comorbidities could decrease survival, but the survival from the MPN depends on the severity of the MPN.
Okay.
Next.
We have another question that was submitted ahead of time, so she might not be on to answer further questioning, but she said her son is 24 years old and has MPN and is active due to bone marrow defects. What do you suggest could save his life long term?
Well, I would have to know what the bone marrow defect is. I mean, does he have any genetic condition that he was born with? You know, that's the thing. I mean, it's there are now even telomere diseases that affect the production of blood cells in the bone marrow, and that's extremely unusual. Orphan diseases, what we call zebras, or very unlikely, very rare conditions. So I don't know, I would have to know what the defect in the bone marrow is. He may have, this is extremely rare in patients in their 20s, but I've had a patient, my youngest patient was 27, extremely rare. She may refer perhaps to bone marrow defects in the chromosomes, and perhaps the son has myelodysplasia also, which is a stem cell disorder, a stem cell disease with defects in the stem cells because of abnormal chromosomes. So I would have to know what the specific bone marrow defect is.
Okay.
But I mean, if there is in a 24-year-old, bone marrow transplant has to be seriously considered. Yeah.
Okay. I'm just going to do one more question. I know we're over the time limit for you. Okay. I was diagnosed with ET with a platelet count between 700,000 and 800,000 and have maintained this platelet count for over 3 years without symptoms or disease progression. Next year, I turn 60 and plan to start taking hydroxyurea. If I choose not to take the drug for a few more years, is there data that indicates that my mortality rate will increase significantly?
No, hydroxyurea would not change your mortality. If your stem cells are going to transform into acute leukemia or you're going to develop fibrosis, hydroxyurea is not going to prevent that. If you delay taking hydroxyurea, I don't believe there is going to be any change in your survival.
All right. Well, did you want to make any closing remarks,
I mean,
Dr.
do
Franco?
you have any more questions? I'll be happy. I have time.
I just got a little bit more detail from the patient we were discussing before with the 20% pancreas left.
Yes.
I think I might send that to you privately,
Okay.
and you can send me the answer, and I'll get that back to her.
Sounds fine.
And so one person asked, what is the argument for taking HU?
HU, hydroxyurea. Well, there is no contraindication. In the past, distant, more than 20 years, there was some concern about increased risk of acute leukemia in patients taking hydroxyurea. That issue was put to rest several years ago in an ASH meeting, American Society of Hematology meeting, in which many experts sat to discuss all the evidence in the literature and concluded that taking hydroxyurea does not increase risk of acute leukemia. So there is no reason not to take it. If you get side effects, which are very, very, very rare, extremely unusual, then you cannot take it. If you develop ulcers in the legs, extremely rare, then you shouldn't take it. But in most cases, it's very well tolerated. There is no contraindication. But at the same time, the lady that just asked about taking hydroxyurea over 60, when she turned 60, she has been diagnosed more than 10 years, I believe, never took hydroxyurea. So many patients do not need to take it. Now, one more name that just came to mind about the lady from Canada or the person from Canada that asked the question about the experts, Dr. Spivak. Spivak is an expert at Johns Hopkins, but he's over 80 years of age. I don't know how many patients he sees. I know he hasn't retired. He likes to see patients. He's an expert in P. Vera mainly, but Dr. Spivak at Johns Hopkins, okay? Anybody else? Any other questions?
And I did get a message that Dr. Mesa is no longer with Mayo.
Okay, Ruben Mesa, okay. Well, I don't know where he is now. And I know that the Dr. Teferi, yes, Mayo Clinic faculty, Ayelu Teferi, Ayalew, Teferi, T-E-F-F as in Frank, E-R-I. Ayelu Teferi, apparently he's still at the Mayo Clinic. And Mesa, I don't know where he went.
I believe he's at UT San Antonio.
Okay. Okay, so any other questions?
I am looking through, I think you addressed the question about secondary versus primary MF in the presentation. Somebody else asked about that.
Primary is when you never had P. Vera or ET before. That the new diagnosis is fibrosis, myelofibrosis. That's primary. Secondary is what develops in patients who have had Polycythemia Vera or essential thrombocythemia before, who develop fibrosis in the bone marrow. That's secondary.
All right. Well, thank you very much, Dr. Franco, and thank you so much for taking extra time to answer more questions.
My pleasure. Good luck to everybody and stay away from COVID.
Will do.
Take care.
All right, Dr. Franco, thank you so much. Everyone,
Okay.
have a wonderful rest of your day.
Great, thank you. Appreciate it. Have a good one. Thank you.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.